You're going to take notes.
I hope so. Cool. Ready? Hi. Good morning. Welcome. We're really excited to share with you the findings of our IPA project. I'm Jocelyn Everode. This is Evan Gallagher, Melanie Chopet, and Anna Johnson. And today we're going to talk to you about school health centers and the community benefit mandate. To start with, we're going to we'll get into the presentation in the structure in a little bit. I'm going to start with an overview of what we're going to talk to you about today. I want to start a little bit with the project background, tell you about our client, tell you about the need for school health centers, and then move on to community benefit summary, which is what we're talking about now, and then finish with a preview of the key points to come. To start with, we'd like to tell you our client's story. We're working with the California School Health Centers Association, and want to tell you a little bit about the need for school health centers. There's a number of benefits to school health centers. One is increased access to healthcare. We've shown that that actually can be very productive. The second is reduced costs, because if you're catching more instances of child sickness up front, you're less likely to need to go to a hospital, and that reduces healthcare costs overall. The third is that it has a positive impact on school performance. You can see it lowers absences, it decreases dropout rates, and it decreases disciplinary incidents. And finally, the fact of the matter is, for many children, they have nowhere to go when they're sick, so they're in school anyway, so there's a nice synergy that actually says we're going to provide you that care while you're in school. We're working with the California School Health Centers Association, as I mentioned. They're a group of advocates who in the 1990s formed this association to advocate for school health centers across the state. In 1994, they received funding from Kellogg, which allowed them to take their mission further. And in 10 years, they've gone from 2 people to 12 people, and they're really doing a lot to further school health centers in this state. I'm going to talk to you a little bit about the services provided by the California School Health Centers Association. They provide medical services, health services, mental health services, dental services, reproductive health services, and a wide variety of other things. I apologize, my cards are out of order here. We wanted to talk to you a little bit also about the opportunity that we had, which is essentially that California School Health Centers came to us asking about the community benefit funding. Community benefit funding is essentially a tax provision of non-for-profit hospitals, and they wanted us to find out how they could use that potentially to increase school funding. And then I'm going to actually let you read our problem definition, so I'm just going to give you a second to do that. This is the project that we actually had. Take a minute to read it. And I won't read it for you, but essentially we wanted you to make sure that you understood that because it was a key part of our project. To talk a little bit about community benefits in general, I'm going to give you a brief overview of the timeline, and then we're going to talk through what they are. The first is that in 1894, there was the first federal peacetime income tax, and at the very beginning they created tax exemptions for not-for-profits. And although it never specifically mentioned hospitals, they have traditionally enjoyed that exemption since. In 1965, with the introduction of Medicare and Medicaid, there was much less need for charity care because obviously many more people were insured. So that changed to introduce the idea of community benefit and what else the hospitals were doing to benefit the wider community. In 2008, there was an IRS Form 990 Schedule H, which essentially tried to introduce more transparency into what hospitals were doing. And then in 2010, there was the Patient Protection and Affordability Healthcare Act, which, as you know, is being hotly contested at the moment. And that sort of furthered the idea of greater transparency around community needs assessment. And this just gives you an overview, we'll get into the details in a minute, of the fact that we're pushing for more and more accountability and more transparency, and we think that has implications for our client. Moving on to community benefit, I wanted to talk, the 4 main categories that you can put community benefits into are charity care, bad debt, unreimbursed costs, and other activities. And the first 3 categories essentially deal with costs for need-based patients that either hospitals are unable to recoup, or that they simply never thought that they would be able to claim in the first place. And then the other activities are sort of anything else that benefits the community. You'll see that that is only 0.1% of the funding. You'll also see this charity care, which is quite a large percentage. I believe it is 8.4%. And wanted to talk to you a little bit about that. That can include a wide variety of things. So charity care can include community health improvement, cash in kind to community groups, health professional and education, subsidized health care, and also medical research. So as you can see, a wide variety of services. And the big takeaway from this slide is that less than 1% of the 11.3% of funding that you can see typically goes to hospitals or to charity care, goes to expenses to the community. The vast majority goes to charity care. And then the last point on this slide that we wanted to talk about is just the state implementation of this policy, because it does vary from state to state. You'll notice that 15 states have a community benefit requirement that's more specific than the federal. California is one of them. Only 5 of those have a minimum amount that you have to spend on charity care in order to qualify, and only 4 have penalties for compliance. So there's a long way to go in terms of actual enforcement of this. Wanted to talk just very briefly about the Affordable Care Act, because obviously that's going to have some major implications for what we're doing. It does introduce the idea of a community needs assessment, and we're going to talk more in detail about what that means in a minute, but it is working with the community to determine what needs to be done. It also introduces penalties for failure to comply, and perhaps the most importantly, increases insurance coverage. So we talked about Medicare and Medicaid, reducing the need for charity care. Under the PPAC, they're thinking that it's going to go from 81% in 2000, the number of insured people is going to go from 81% in 2010 to 92% in 2019. And we're going to talk a little bit about the implications of that. So moving forward, just talking very briefly about what's going on in California. In California in 1994, they actually introduced legislation that's more specific than that which exists federally. And the really key points is there's an annual community benefit plan that you need to introduce. It needs to be prepared with every 3 years you need to do a community needs assessment. It must be tied to the mission statement. Another key point is service areas. In other words, the area that you're serving, your community, if you will, can be very generally defined. You need to have measurable objectives and a plan to share. And then the last thing to note is that currently in process, in 2012, there's an additional bill that's currently on the ballot, and excuse me, I just noticed a mistake in my slides, with 5%, which will say that in California you have to dedicate 5% minimum of your expenses to this charity care, and it broadly defines charity care to include community building activities. It also increases oversight and accountability. To sum up what I sort of just talked about, I think the big takeaways is that there's a very wide amount of latitude for hospitals in terms of how they actually implement this community benefit regulation. It's also because there's a trend towards increased accountability, and because less of the current work is going towards charity care, it seems like it might be a good time to get involved. Moving forward, I'm going to introduce Evan, who's going to talk a little bit about funding and the impact of advocacy. Then Melanie, who's going to talk about some of the things that hospitals can do. And then finally, Anna, who's going to talk about community strategies for involvement. So with that, I'm going to hand it over to Evan.
Thanks, Jocelyn. Hi, guys. I'm going to talk first a little bit about what we learned outside of California. So the first thing our client asked us to do was look at some hypotheses that they had about differences outside of California in terms of sponsorship of school-based health centers by hospitals. And just looking at the table behind me, you can see that in the 3 states that have the highest levels of school-based health centers, they also have much higher levels of sponsorship by hospitals, 40 to 60%, whereas almost no hospitals in California are sponsoring the 190 school-based health centers that we do have. At the same time, they asked us to go out and look at, are there key enabling policies outside of California in these states, in this case it's Michigan, Louisiana, and New York, that are leading to these outcomes. And just at a very high level, you can see that the 3 main ones we identified right away are that there's a dedicated grant funding mechanism at the state level carved out for school-based health centers to fund, to pay for hospitals to sponsor them. There's a state-level office, usually a joint office between the Department of Education and Health, to support this process. And there's usually a clear defined amount of spending when a hospital gets involved, how much funds they need to match. So what we found, we went out into the world and talked to a number of hospitals in these 3 states, and we looked at what a factor these enabling policies play, and we found that each state really supports hospital involvement in school-based health centers in pretty similar ways. The dedicated grant-making process, the dedicated funding is usually a competitive grant process that's fairly similar across all 3 states. It really formalizes and publicizes the process for hospitals to get involved in sponsoring school-based health centers, makes it clear how they can do it. It also defines the amount of money that they need to put forth and the amount of money that they're going to get annually. So it really helps the hospitals understand what their costs will look like if they sponsor. And then further, the states have created a support infrastructure and an information and knowledge base in the Department of Health and Education in the form of these school-based health offices that hospitals can access. And this helps hospitals link up with potential schools when they come to the state and say, we want to start a school-based health center. What communities should we potentially serve in our area? And it also provides support to the hospital in the grant application process. And then once the hospitals and the school health center are up and running, it helps them with a lot of legal contractual issues that are pretty confusing to hospital administrators. The major finding is that what we really learned is that because the cost of sponsorship, it's usually between $1 million and $2 million a year, it's pretty low relative to the rest of things that hospitals spend their money on. It's not typically done and counted as part of community benefit. If it is, community benefit funding is not the main reason that hospitals are getting involved. It's really a variety of other factors, but it's mostly the relationship that already existed with the hospital and the school-based health center and the mission of the hospital is what we found in our interviews. So in a lot of cases, mission-driven relationships are in part because the hospitals are Christian organizations and this has always been in their mission to serve the community. In other cases, it's because it's a rural hospital and rural hospitals feel the need as the only provider, the provider of last resort of healthcare to do this in schools. Beyond the mission-driven and sort of mission reasons for sponsoring school-based health, the hospitals we spoke to also mentioned that they do see some positive return on investment. They view it as good marketing and PR to have their name on consent forms and sometimes their name on a mobile van. But overall, it's viewed as a money loser, a loss leader of sorts, in that the hospitals think that they can never really make it a revenue-generating positive profit center, given that they can't reimburse. And the major factor is here that they can't bill at the levels that federally qualified health centers, community health centers can bill at. So in many cases, they're receiving much lower rates of reimbursement than similar community health centers around the country when they run school-based health centers. So ultimately, the finding here is that the decision to sponsor school-based health centers is really ideological and mission-driven, as opposed to a financial decision. Given what we learned about the regulatory framework outside of California and some of these enabling policies that did drive sponsorship of school-based health centers, we looked at what our client could do to advocate for changes. And the 2 main things they could do is A, advocate for stricter and more restrictive clauses in the community benefit definition in California that would force hospitals to do more things like school-based health centers and do more things that count as community health. Alternatively, to push for a dedicated grant mechanism in California's budget and a supporting office like the other states have. Both of these options, though they would probably drive increased sponsorship, we realize are very difficult for our client to push for and have a pretty low possibility of success, so we decided not to advocate for that due to the high costs and risks. But one thing we did learn is that there are some alternatives out there to full sponsorship, and that a lot of, given that FQHCs receive much higher rates of reimbursement, a lot of hospitals outside California mentioned that they, or hospitals similar to them, had stepped back and stopped sponsoring at one point, letting an FQHC come in and become the main sponsor of their school-based health center, while they remained involved, donating a lot of in-kind services, in-kind products, things that they had at scale, like implementing an electronic health record system, something that they could do fairly easily, but taking away a lot of the risk and financial risk and reputational risk of running a school-based health center and letting the FQHC take over. So we see this as an alternative way for school-based health centers to access hospital funding. With that, Melanie's going to talk a little bit more about how we can engage hospitals in California.
So Evan just took us through what we learned from hospitals outside of California and also discussed an alternative for advocacy in order to increase hospital sponsorship of school health centers. I'm going to talk about some strategies we have to actually increase hospital sponsorship of school health centers through creating a hospital champion for school health centers. This strategy is a part of our overall recommendation. Our overall recommendation is that there needs to be 2 champions in place in order to either start a new school health center for a community or further a hospital's relationship for a school health center. One champion needs to exist on the hospital staff, preferably in the community benefit department. The other champion needs to exist within the community. I'm going to discuss the strategy for cultivating the hospital champion, and then Anna will discuss the strategies for cultivating the community champion. So, hospital strategies. Within this section, I'm going to start by giving an overview of how hospitals currently started their involvement in sponsoring school health centers. Then I'm going to talk about what a hospital needs in order to become a champion for a school health center. Finally, I'll wrap it up into what our overall recommended strategy is for cultivating that hospital champion. This strategy comes from not only the research previously mentioned that we did, but from also interviewing hospitals in California that currently sponsor school health centers and reading many community benefit reports that all nonprofit hospitals are required to submit to the state, outlining what their community benefit programming is. So, genesis of support. From the hospitals we interviewed in California, several themes came through in every single interview. The first theme is that every single hospital could name a specific staff member that believed in school health centers as a viable public health intervention. This staff member, in the interviews we conducted, started this relationship with the school health center and the community several years before the community benefit mandate. Another thing that came through in all the interviews is that a school health center really connects to the hospital's mission, which Evan mentioned before. He found hospitals outside of California also mentioned as key in their relationship with the school health center. Also, a hospital needs to understand how a school health center connects them to the population they serve. California hospitals, also how hospitals outside of California noted, that school health centers actually serve as marketing. And they help the community understand what the hospital is all about with its mission, and also help in the grant fundraising process. And then finally, as I mentioned before, in all the interviews, we did not find the community benefit funding mandate as a part of motivation for beginning the school health center. So I just covered the genesis of hospital involvement in current school health centers from our interviews. Now I'm going to talk about what we think hospital needs, what a hospital needs in order to become a champion for a school health center. A hospital needs to understand how a school health center meets their community's needs. A hospital also needs to understand and see evidence that there's school support for a school health center, so that they won't be the only champion of this public health intervention. Also, a hospital needs to understand how a school's health center aligns to their current skill set. Finally, a hospital needs to understand, like I mentioned before, Finally, a hospital needs to understand how them supporting a school health center fits into a network of providers for that population. So if a hospital sees that there are other free clinics or other FQHCs supporting the needs of a population, they won't see it as their place to champion a school health center. So I want to tie this all together, give you an overview of the recommended strategy, and then I'm going to put some meat on the bones of the strategy with a few specific examples from hospitals we interviewed. So, our strategy for cultivating hospital champions. Identify potential hospital staff. Find the names of people in the community benefit department that could be potential champions for school health centers. That person then needs to understand how a school health center will really connect to their hospital's mission, the population they serve, and directly addresses a need that the population they serve has. Finally, the person in the hospital needs to understand how a school health center's design aligns with the skill set they have as a hospital. So to put some meat on that skeleton, identify potential hospital staff. As I mentioned before, every single interview, the person interviewed could name the person who was a champion of school health centers as a public health innovation, a person who was excited about it. Communicating connection to mission, population, and community need also came through in every interview. In fact, several hospitals use their school health center as a way to increase grants by saying, look at what we do. We're here. Look at our van. You can see our name. You can see the children in the community coming in and out. That's us. That's who we are. And they use that as a vehicle to increase grants and marketing for their hospital. And then finally, align school health center with the hospital skill set. This came through when we talked with Children's Hospital of Oakland. They said, we are a premier institution in dealing with children terminal disease and illness. We wanted our school's health center to reflect that. And so that's what we mean where we say this potential champion at the hospital level needs to understand how that hospital skill set can really come through in the school health center and what that school health center provides. I just walked us through the strategy we have for cultivating a hospital champion for school health center. Now Anna's going to walk you through our strategy for cultivating community champions for a school health center.
Thank you, Melanie. So, as mentioned, in order to have school-based health centers funded and access in the community to health, what has been one of the biggest motivating reasons for these to continue have been the alliances and the community members that are health advocates for youth. And what I'm going to do right now is just talk about the different partnerships and why they exist and why they're needed in order to advance the community and school health centers movement in California. Okay. Now, California is a little bit different than any other place in the world. It is very diverse, and it's diverse in a lot of ways. And this is why we need community partners from the specific communities that are going to be champions and going to advocate for school-based health, because they know those communities. They know them geographically, whether it's urban or rural. They know them financially, whether it's low, middle, or high income. School-based health centers are a positive resource in any financial community. Ethnic and cultural diversity and medical needs are something that needs to be considered in whatever community you're going to deliver medical services. And that's why community partners are necessary, because they understand those needs. Language differences in each community need to be taken into consideration. Educational needs. What do they know about health? What do they want to know about health? These are ways that community champions and partners in school-based health can become in alignment. And finally, the school health center diversity. We have 190 school health centers in California. None of those are the same. They're each unique. And they're each unique because all of them are tied with the community that they serve, which are all different. And that is why we need these community partners in California to be aware of what's going on and to be able to advocate for improved health. So who have been the community health advocates and champions? There's a huge range. It can be healthcare professionals, educators, people in the school district, hospitals and healthcare providers, public, private, and nonprofit organizations that serve to advance health causes, as well as local and state political supporters. So who could be a health champion is anyone. It's you, it could be anyone that wants to advance the health of youth. And we see that evidenced in our communities here. One thing that CSHCA, our client organization, has done a very good job of is building awareness in the state of California for school-based health centers, what they do and who they serve, and how we can inform these places of health to have best practices functioning and to have the most current knowledge in action. So one thing that we want to suggest with community benefit funding to our client is to continue this pattern of informing and building awareness that eventually leads to innovation, okay? What we want to first inform our community partners about through CSHCA is the changes under the Affordable Care Act. So what does that mean? Medicaid is now being more funded for more youth, which means higher reimbursement, which means school-based health centers might be a more viable option, right? It means many things, and our champions need to know that. Community benefit funding possibilities. There is a wide range of services that qualify because of the vagueness in the definition of community benefit funding that hospitals could use to support school-based health centers, from in-kind donations, supporting staff. They could pay for facilities, they can pay for utilities, any of those services, as well as providing care that is not reimbursed, can all be covered under community benefit. One thing that CSHCA has done has been to inform best practices for funding to their community partners. What we would like to see is to add, with community benefit, what are those best practices for increasing funding added to that mechanism. And finally, what I'll talk about next are the importance of the community needs assessments that are happening. School-based health centers are already performing community needs assessments for their communities, and hospitals under the Affordable Care Act need to assess their communities and deliver targeted services. And so there's room there because both organizations are assessing the needs of the community to collaborate and bring it together. And that's what I'm going to talk about. So there are many entry points for collaboration between community partners and hospitals. This entry point can be just by finding a hospital with a strong mission statement and then jumping in from there. Or you can start by conducting a community needs assessment, as is already happening for your community, and then bringing that community needs assessment to the hospital and advocating there. What essentially we would like to see with a collaboration between hospitals and community partners are that they're matching the needs found in their service areas, providing targeted services to that community through school-based health centers as a vehicle to change those health outcomes in that community, and to be able to name the costs and benefits of those services, and when employing those services, to ensure that there is a billing mechanism and a reporting mechanism that will support their IRS tax form for the hospitals, okay? So that pretty much summarizes why we need community partners, how they can get involved to build collaboration between hospitals, and hopefully to increase funding in the already existing 190 school-based health centers, and then to build upon that with the changes under Affordable Care Act to maybe increase the number of school-based health centers because of the possibilities of collaboration with hospitals. So Jocelyn's going to review and summarize our presentation. Thank you.
All right, I'm going to keep this short and sweet because I think that my colleagues did an excellent job of summarizing what it is that we have to tell you. I think the overall takeaways that we wanted to leave you with were the fact that looking at sort of the three different strategies, advocates, hospital champions, and community champions, we think they all have some merit, but we're also understanding of the fact that there are limited dollars. So given that, we would recommend not focusing on the advocacy really at all. We think that that trend is progressing by itself and that there's limited additional things to be gained by the addition of a stick to make hospitals use community benefits. We think that cultivating partners within hospitals is very, very important, but we also, again, realizing that there's limited dollars, think that to focus on community champions has incredible possibility in terms of bang for buck and in terms of really having some targeted interventions that could greatly increase the partnerships between community benefits, between hospitals and community organizations, and potentially really increase funding for these very important school health centers. With that, I'd like to turn it over to questions. Thank you.
Thank you very much. I'd like to short circuit the questions, and I would prefer to pass on my comments if you
Of
like.
course.
Can I have the clicker, because I might want to go back and, can we keep the slide
Yeah.
that you go, and I'll just click through it. So great job, really, really great. I mean, it's amazing how far you've come in a short space of time. I'm going to go through sort of from top to bottom, so to speak. So
I'm going to go back to...
tell you what, Jocelyn, maybe I'll just take the clicker and just...
Yeah, no, I was going to find you the...
Thank you. Softball wasn't my strong suit in elementary school.
This waits for being your professor.
Let's see if I can, there we go.
Are you taped also?
Okay.
Maybe-
Do you want this taped?
Yeah, that would be great.
Okay, so it'll show. There was a little too much kind of several layers of throat clearing here, lists and then lists. And a verbal tick is you, Jocelyn, more than you needed to, sort of gave subheads as you talked. I want you to understand this, let me give you the topic of what my next sentence is. And then I want you to understand this, and let me tell you the topic of my next 3 sentences. It's a little bit of a verbal tick. You don't need to do that quite that much. Conceptually overview, at the end you said we had 3 strategies, and I didn't get that at the beginning, but I also don't think you really do have 3 strategies. I think what you're talking about, in fact, is you would want to put this at the very beginning, that there's a strategy of advocacy at the policy level, and then there's a strategy of partnership. And partnership actually requires finding both a hospital partner and a community partner, and we'll talk about both, and then it may be more feasible to start with the community partner who then would find the hospital partner. The other thing I would say is I wouldn't call it a community partner. I think it has to be a school-linked partner. I think it has to be a person who's either in the school or closely connected to the school. So I would call them a school-linked partner. So that's conceptually, and I think you need to put that up front.
That's great.
I suggest do not put that full statement up there, problem statement. It's actually not very sexy. It's kind of wordy. Just simplify it a lot. You can save yourself the slides and some time. I don't think this one you don't need that at all.
Okay.
And I think I would focus now on California. Don't do national. Start by saying the policy context in California is that there's a mandate, but it's not enforced. It's a community benefit mandate. It's actually based in federal regs. It's not enforced. And then I would absolutely, and I wouldn't call it PPAC when you refer to it, by the way. I'd call it the AC. If you use an acronym at all, call it ACA, because that's what people generally do.
Okay.
I was puzzled a minute there. And I would say, I'm going to really drill down and say there's one reason to think about this right now is that it is potentially a transformative moment if the ACA stands. And then give us a slide on the transformation of the community benefit, the change in insurance that will make this, say, look at this, they're getting all that community benefit out of charity care right now. And if ACA goes through, that will go down, and you had some numbers, put them on the slide, that got lost.
Okay.
I thought that was because that's a leverage moment, otherwise it's the leverage, so there's 2 things, leverage moment plus just creating a partnership. Okay, so put on slide the change in the unreimbursed formula. All right. All right, where are we? Keep going. Yeah, so I've given you some comments. So this one you would expand, it was supposed to be 2011, or 2012, whatever. So then that would partner with the ACA. SB 697 might be the next piece to say, does ACA and then no.
Well, so can we just talk about this? Because this is
No, let's put
actually,
it's techie, so tell me if I'm not right about that later, but it's just an idea.
so just really quickly, the problem is that
Okay.
California already has in place a lot of what the ACA is doing.
Oh, okay.
So that's why the weird,
Oh, okay. Well, you can, okay, oh well, oh
but
darn.
clearly that wasn't clear, so.
Now, Evan, so overall, I mean, I want to say good, but with those comments and with those comments. Here, current landscape out of other states as a comparison. I don't think you need this because you say it here, and because you're going to end up saying this isn't going to work.
That's true. question.
I mean, I think it's cool, and if we thought it was gonna work, I'd love to really see that, but you got my appetite whetted, and then you said, never mind, moving right along here. So we're staying with this one. And I think the dedicated support of, dedicated grant funding, the point there is that there's a fiscal relationship. That by dedicated grant funding, what you're actually saying is that there's a grant, the state has created a fiscal arrangement that's a state-hospital partnership. So dedicated grant funding is kind of generic. What you've actually got there is a partnership. So I would reframe it like that. I would say also what the hospitals are contributing is 1 to 2 million. And then I would say we're going to talk sponsorship. The other big conceptual idea is sponsorship or partnership or support. Maybe even 2 ideas, maybe 3 ideas in levels of depth or intensity or whatever you want to call it. Sponsorship, partnership, support seems to me to be one way to think about this. And say, if we could get $1 million or $2 million out of every hospital in California, how could that be used? Could it be sponsorship? No, probably not, but unless. So framing it in that way. Melanie, lovely hand gestures. I felt like you were a choreographer, because there's so much variety. And my identity is to deliver charity care to people with cancer or whatever. And then we could expand it. Come on, come on. It's like you've been watching preachers on TV or something. I mean, there's a quality to that. It's theatrical. It's very, I hadn't, you had one thing you said, you said this very interesting idea. But then, where? Here. Underneath with a network of providers, you said, well, then they'll look around and see an FQHC and a community-based clinic and they won't want to do it. That was a downer. Why not say they'll see a this and a that and then they will want to do it?
That's good.
In general, in your writing too, avoid negative, not positive. It just works better. Anna, don't put hospital personnel on your list of people. They're hospital champions, no?
But sometimes they're the ones that start them.
But they belong in the hospital championship conversation. Conceptually, you guys are set up. You can have a person in the hospital, you can have a person in the community. So you want to keep clear on that. And I would definitely call it school linked. And then you're saying it's not just who they are, but what they do. And I'm not sure, you're getting down to micro when you've got stable system for billing and reporting. You're way beyond thinking about how to get this going. So I would be very focused on how to generate, to develop, to initiate.
Can we push, so, go ahead.
Well, I guess here, I think what I forgot to say when I was talking was that we see that hospitals are pulling out because of the loss.
Oh.
And that's why, when you're establishing, it's important to
Think about this ahead of time.
You have to think about this when you're establishing up front, so that way you get the sustained partnership from the hospital. And if community partners know that going in and can, oh, well, we know that this is important.
So here's something to think about. You might say, in cultivating a community partner, actually this, you still don't want to have it here. What you want is to say, and by the way, all of you, try and get your acronym of your client clear. I got really confused.
It's terrible. It's the worst.
Well, find a simple name that we can all understand, because I gather you've got some letters reversed somewhere maybe, but I'm not sure. I'm completely puzzled by this acronym, so maybe it doesn't matter because they're the only people who can see
say our
this.
client or
They will want to provide a guidance packet for community advocates. Rather than saying what the community advocates are going to have to do, your client should create a toolkit for the community advocates and for the hospital advocates. And the other piece that's missing here is building that bridge between the community partner and the hospital partner, because you actually need both. One needs to find the other. They don't have to be of equal strength, but one needs the other. Okay, we need to move on. We're already 7 minutes behind, but we started a little late. I know. They're eager to go. So I'm sorry, this is looking